Hello, everyone, and welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I'm a filmmaker and writer that's been working with CCF for over 10 years, creating all kinds of video content, live video series like the one you're going to watch today, patient-centric documentaries, treatment-based videos, conference and event videos, hundreds of videos over the course of 10 years, but all with one mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we are here to do today. So if you are new to this journey, or if you are new to the show, first of all, I want to say welcome. And my first ask of you is to reach out and introduce yourself to the community. Tell us where you're signing on from. You can see people in the comments are already doing so. The value of this show that you're going to watch today is really twofold as I see it. One, the information you're going to get from our excellent guest, our returning guest today, who I'll introduce in just a moment. And two, the shared experiences and shared stories from the community. I have never seen a community as strong and supportive as the NET community. And I encourage you to engage with them, reach out to them, embrace them. They will embrace you back. So introduce yourself. You can see we have people from Nepal, California, Alabama, Canada, Montana. Hey, Kelly, let us know where you're from. Say hello to everyone, and we're going to go ahead and start the show. Before we do, we always want to thank our sponsor, Ipsen Biopharmaceuticals. We simply couldn't do the show without their support. And we also include this disclaimer from them at the beginning of each program, and that is that the opinions expressed today by the guest presenter, as well as the questions asked by the audience, that you all at home, have not been created or suggested by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. So, and this is the real takeaway, audience members should not rely solely on the opinions or information expressed by the guest today, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, like disclaimers are, that's a little wordy, but the point is that last line. We don't know your specific case, so we're going to give you some good general advice, some good answers to your question. Take those questions or those answers and that advice back to your home team, which does know your unique case, and make the best plan and path for you moving forward. Okay, that's my second ask of the day. Now, I am very excited to welcome back to the show, who was here a little bit over a year ago, Dr. Karel Pacak. Did I say that right, Dr. Pacak?
Yes, I did. I think that you did a good job.
Thank you very much. For those that weren't here last time you were on the show, or might not be familiar with your work and your role in the NET community, tell us a little bit about what you do in this community.
So as you know, I'm working at the NIH and focusing on neuroendocrine tumors, especially, my focus is on Pheochromocytoma, paraganglioma. I've been in this business, for a long period of time. It's approximately more than 20, or I would say it would be, 22 years. And we really see many patients with Pheochromocytoma, paraganglioma, thanks to the NIH and the support that we are receiving. The number of the patients these days is approximately 200 to 300 patients per year. And this institution was a little bit even more before COVID, but of course, the COVID changed a little bit everything.
Sure.
What is important for our actually program here related to Pheochromocytoma, paraganglioma is that we are providing, comprehensive care.
Mm-hmm.
And if somebody knows about the comprehensive care, it's not only, that we see the patient, we diagnose the patient, and that's it, and we send the patient home and for example, to their states and to their, the initial or, referring institutions. But we also provide, for example, for patients, surgical surgery, sometimes, very complicated surgical procedure, those that we can do at the NIH. We cannot do everything, of course, at the NIH. We provide also the therapeutic options, and we provide a patient with the access to several clinical trials and very interesting also imaging. And some of these imagings are available only at the NIH. So I think that this is comprehensive care. And of course, I've forgot the genetics, because these days we do not only, Pheochromocytoma panel for patients. You may know that usually the Pheochromocytoma panels are usually for 12 genes, but we provide patient not only with these 12 genes, but for 500 genes, because some patients may not have mutation in known Pheochromocytoma paraganglioma genes. So especially those who are operated here, we have a very special setup, with the pathology department to provide very good genetic testing. So it's comprehensive care. It's under one umbrella, the NIH, and this, it's like one package, that
Sure.
we give to our patients.
Absolutely. Outstanding numbers so far today, folks. That tells me that we have a highly anticipated guest, which I knew would be the case. Another thing that has helped elevate the knowledge and the attention of pheochromocytoma and paraganglioma is the Pheo Para Alliance. Last week was officially Pheo Para Awareness Week, and I know you spoke at that conference, right?
I did.
The Pheo Para Fearless Conference, which I think is a really cool name. But the Alliance has been very supportive of us, and we want to give a shout out to them. And I think that's really cool that we're bringing so much awareness to this as well, to Pheo Para patients as well. So, folks, let me ask you a quick question, Dr. Pacak. I may have missed this in your intro. Are all of your patients Pheo Para patients, or just a percentage of them?
I'm not sure what you meant in terms of percentage, but so because our program is especially focusing on Pheo paraganglioma,
right?
So all the patients that I mentioned,
Got
the
it.
number, all the patients with Pheo paraganglioma. Of course, we are sometimes seeing, some other patients with neuroendocrine tumors, but we always are working with NCI. NCI stands for National Cancer Institute.
Yes.
Because we are very highly specialized here at the NIH. The reason is being highly specialized is that we know a lot about the disease. We have a lot of experience, and we can provide the best care to our patient, which I think that we are doing, at least until now. This is my personal view.
Yeah, I think that's fair. And you were talking about some of the trials. I know I've announced this to the people listening. This year we are doing another patient-centric documentary series. We just released the first one a week ago of Eileen, which is, folks, if you haven't seen it, it's at the we've pinned it at the top of our Facebook page. But our next patient, the next story that's coming out in September, it's now September at the end of the month, is involved in one of those trials. So we talk a little bit about that in the film. So I know that a lot of people are excited about those, and we'll talk about them a little bit today, I'm sure. Folks, here's the deal. Go ahead and start sending in your questions. We're going to get to as many of them as possible. We only have an hour with respect to everyone's time, so we're going to try to get to as many as we can. We may not get to your question, but I encourage you to follow up with us. If we don't, tune in next week. That's our goal, to get to your question, but just understand that we get so many every week that we just can't get to them all. But here's a little tip that will help you get your question answered. We don't know, or our guest doesn't know your specific case. So they can't be really dense and nuanced and very case-specific questions, or that doesn't help us. So a lot of people try to add information about their specific case, I think, to help clarify, but it becomes so much that we can't really narrow it down unless you are actually the guest's patient. So try to formulate your question in a generic way, in generic terms. Dr. Pacak, what should I do if I'm experiencing this, or who should I speak to, or that sort of thing. And I know you'll have follow-up questions. So if you do, ask them in little chunks, not 4 questions in one comment. Just ask them in little pieces, and that'll make it a little bit easier for me to get those questions fielded, because that's what we want to do. So that just helps me do my job a little bit better, which is, of course, to serve you and get your questions answered. And another thing that I ask as well, if you see a question that you like, or you're interested in, or you want the answer to as well, that someone else asks, just under that question, you can like it or love it, or any of the emotions Facebook allows you to use. But what they do is they effectively upvote that question. If I see 9 people are interested in that question, I know that's in high demand, and I'm going to make sure to get that one across. For those people who aren't here, go ahead and tag them in the comments, let them know what's going on. But you or they will be able to replay this video at any point after the broadcast is done. It will live here under the videos tab on the Facebook page, and starting Monday, I'll repost it to YouTube for those people who don't have Facebook. So you'll be able to watch it, they'll be able to watch it, but the real value is being here in the session, interactive, and getting one of the questions that you've been struggling with answered. Hopefully that is absolutely our goal. So looks like we've got great numbers already.
And I can also say, so if, all the questions will not be answered, you are always welcome to send me email, and I will be happy, to communicate with some patients who definitely need, some questions to be answered. And those questions are very important. I don't mind if I will be sent email after this meeting, and I can promise you, and most of you, you know me, that I always respond. So I will be happy actually to communicate with you, because we have a 1 hour. 1 hour is not, very long, but, I will do my best.
Well, folks, that is a very, very great offer for you. So you heard Dr. Pacak. Take him up on that. That is a very kind offer. Appreciate you. Okay, so questions coming in from, let's see. If a pheochromocytoma patient has elevated norepinephrine, what testing should be done?
Yeah, so if there is elevated norepinephrine, we always ask why the norepinephrine is elevated. If the patient has the pheochromocytoma, yes, so we are actually thinking about the pheochromocytoma, especially based on the new guidelines. Guys, remember, new guidelines 2 times above the upper reference limit. So this is always worrisome. But you always ask yourself, do I have any medication that can actually increase my norepinephrine that can be actually false elevated, which means, the results are false, and you have to think about it. And there is a lot of medication that can do it. Just, for your information, very often, for example, the drugs for allergies, or the drugs, for example, patients are using for anxiety, depression. So you have to always tell the doctor if you are on any medication, because the only option what you can do to stop the medication and repeat the test, or, to be tested with something which is called clonidine suppression test. There are some limitation for clonidine suppression test. We don't have actually time to go through that, but remember, drugs, that is the most important, and anything with the kidney. So if you have something with the kidney and, the drugs, you always have to tell the doctor, because, you will get the workup for $10,000. You will spend a lot of money as a copay, because these days it's very expensive. And finally, somebody will tell you, because you use this drug, actually many tests were done, they were useless because you don't have a pheochromocytoma. If you have a pheochromocytoma and you have an elevated norepinephrine, you have to be on blockade. And the blockade is so-called adrenoceptor blockade, usually alpha blockers and beta blockers if you have a tachycardia.
Got it. Thank you. And thanks for your question. From Rick, are you familiar with lanreotide and paragangliomas, and what are your thoughts?
Yeah, I am familiar with lanreotide. Lanreotide can be sometimes very good, because the pheochromocytomas, paragangliomas, especially paragangliomas, which are outside the adrenal gland, and especially those that are located in the head and neck, so are very good actually target for example, so-called somatostatin cold analog. Cold means, like lanreotide and octreotide, because they can stabilize these tumors. They cannot shrink those tumors, but they will stabilize those tumors. And that is very important, because not every patient can be operated, especially when they have a head and neck paraganglioma. For example, foramen jugulare paraganglioma usually cannot be operated, and every millimeter counts. Every millimeter counts. So if you get, called somatostatin analogs, and for example, you cannot get the Lutathera treatment, which is radioactive treatment, which also works on the same receptors, you can get, for example, lanreotide. The lanreotide is used with the dose 120 milligrams, and it can be used usually every 3 to 4 weeks. And if the patients need, sometimes in some patients, not very often, in some patients can be used even every 2 weeks. So yes, the medication, it's not proved very well that, because there is no study showing, the outcomes and benefits. But I can tell you, I have many patients on lanreotide or octreotide, and their tumors are pretty well stabilized. So if you don't want to go through other treatment options, or other treatment options are not actually available to you or cannot be done, the lanreotide is definitely something that I always consider, especially for patients with head and neck paraganglioma.
Got it. Thank you. I'm thinking that you probably are well aware of this. That the neck community is very well educated when it comes to this disease. But we always get people that are new to the show and new to this journey. And so I always like to play to them as well. Could you do me a favor and give me a basic understanding of pheochromocytoma and paraganglioma within this disease, if someone hasn't heard that before and they're confused what that means?
Yeah, I can do it. We will need 2 or 3 hours. So
Perfect. All right, guys, the show's going to go a little bit longer today.
that's okay. I am pretty sure they would stay with me. I would stay with them.
I bet they would too.
So I wanted to tell you, pheochromocytoma paraganglioma, always if you suddenly have something which is called, for example, palpitation or tachycardia, or you have a high blood pressure. For example, you are lean, you are not obese, you are living healthy life, you are even exercising, and somebody is finding high blood pressure. Yes, your parents could have a high blood pressure, so it's maybe some genetics. But if you are young, high blood pressure, otherwise, healthy, you take one medication, is not helping. You take second medication, is not helping. You take third medication, is not helping. That's worrisome. Also, what is worrisome, if there is this hypertension, the hypertension comes in spells, okay? In some very short periods, like, you suddenly feel that, you have like, heat in your head, you have a headache, you have sometimes sweating. Sweating is very important. And then somebody will measure your blood pressure and heart rate, and they will find that blood pressure is high, heart rate is also high. That's the problematic situation. And if you're, for example, friend or somebody, your spouse, will look at you and say, oh my God, I feel that you are a little bit pale, like you have some paleness in your face. That's exactly something that you should be aware of that. So don't, sometimes when you go to cardiologists, and I respect them highly, but sometimes they will do, stress tests, they will do echo and everything. But, that's not always necessary. If you tell them I have a sweating, I have a palpitation, I have a high blood pressure, especially going in the spells, they should first actually to measure catecholamine and actually metanephrines, either in plasma and urine, to rule out pheochromocytoma paraganglioma. If this is ruled out, then you have to go through the test that, again, they are pretty expensive tests. And as I said, the co-payments and everything through insurances are very high. So be aware of that. Sometimes, simple tests that co-payment can be $20, $30, can reveal what you have.
Got it. Thank you very much. Next question from Doug: is MIB1 score the same as Ki-67?
Yeah, so Ki-67 is proliferation index is the same, so because we have proliferation index, we have also something called mitotic index, but we go with Ki-67, as the proliferation. So if the proliferation index, it's actually high, so we have suspicion that these tumors are growing, fast, and we have to be careful. But it's considered as the same, and we usually use Ki-67 which is as a proliferation index. But mitotic index is also very important, so for these tumors, but the data is very limited. So Ki-67 would be the one that I would always ask from pathologists to give me, the information about that. Okay.
Got it. Thanks, Doug. Appreciate your question. Let me know if you have another one. From Diane: how important is getting your serotonin level, and who should do it, a cancer doctor or primary doctor?
Oh, serotonin level, no, usually not important. If you go to carcinoid, yes, because there are some pheochromocytomas together with carcinoids. So it's very interesting, challenging question, but there are very, very, very few. And I thought maybe 2 or 3 patients in a 20 years history that had carcinoid and pheochromocytoma. And yes, then serotonin, of course, especially, for example, if you have some redness on your chest or in your face, sometimes, for example, if you are eating, certain food, or, for example, or drinking, wine, alcohol, so you have to be aware of that. Usually we don't measure serotonin. Serotonin can be measured, but it's complicated, and it can be some interesting measurement is in platelets, but usually we measure metabolites of serotonin 5-hydroxyindole acetic acid in the urine. I suggest that, for 24 hours, that will reveal, what is going on. But the combination of carcinoid with serotonin and Pheo is very rare. If you ask me about serotonin, whether it can be produced by Pheochromocytoma, I have not seen it. But in medicine, everything is possible. So my answer would be yes, but I haven't seen it. It's very, 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 most likely very, very, I would say a rare situation.
Understood. Thanks, Diane. This is a comment. Kristen says, just want to thank you for being one of the only doctors I've ever had that responded so quickly. I'm looking forward to being your patient in the very near future. So
I told you at the beginning. So if you send me email, and you really are encouraged to send me email, and I'm pretty sure Ryan or somebody else can provide you with my email. I don't mind. My email is not hidden or somewhere, going, through some regulatory issues, etc. So you all are encouraged to send me email, because I like to help you. And of course, to be honest with you, I also learn from you and from your suggestions and from your actually situation and what you have.
This last point you just made is echoed quite a bit, that you learn from them as well.
Yeah.
And folks, you heard it here. I mean, it's a very great offer to reach out to Dr. Pacak. But this goes back to what I was alluding to in the beginning of the program about the strength of this community. It's not just within the patients; it's within the patients and the providers and the support givers and everyone involved. And I've heard that sentiment shared before, that it's not just to help them, but you also learn from them. And I love that kind of symbiotic relationship. I think it makes the community really, really strong. I think it really does. From Effie, what are your thoughts on a Pheo Para that is cyclical? What is the best way to catch it when active?
Oh, that's interesting question. I will tell you, if you think that is cyclic or something like that, you are most likely talking about the spells that I talk about. And the spells are actually there because, the catecholamines are episodically released. And this is why, for example, you have most likely episodic hypertension, episodic, tachycardia, anxiety, nervousness. This is another actually the sign that patients they have. Yes, however, about the diagnosis, that is not the most, it's important for clinical diagnosis for to proving the Pheochromocytoma paraganglioma, the presence of this tumor. You will not go with the catecholamines because, as you said, it's the cyclic. So it's going up and down. And if it is down, and if you would take, the blood sample, you will not have anything. Everything will be normal. So this is why we are not measuring catecholamines. We practically abandon that, although we are doing it at the NIH because we are as a clinical research institution, but we measure metanephrines. And I will very simply say metanephrines are continuously released. So it doesn't matter whether you have a spells. If you have a tumor, the metanephrines will be always elevated, okay? So do not put so much into catecholamines that the doctor will tell you, oh yes, we will measure catecholamines, we will tell you what is going on. No, tell them you don't want the catecholamines to be measured. You want to have so-called metanephrines or metabolites of catecholamines that they are called metanephrines. It's available everywhere. They should do it. And I'm telling you, doesn't matter whether you have a spells, whether you are sleeping, whatever you are doing, watching TV, if you have a tumor, they will be elevated.
Got it. Thank you so much. And thanks for your question, Effie. Good to see your name and your face a little bit. From Rebecca, what are your thoughts on reducing Sandostatin dosage?
Yeah, it's interesting question. Yes, you can, if you have a stabilization of the tumor and you have been on, this medication for a long period of time, there are no changes in the tumor size, you are feeling well, you can reduce, you can even stop, you can have, the holiday, from that, for period of time, and to see, what is happening. Because I had some patients who stop it and the tumors are actually stable for a certain period of time. As I said, there is no typical study that I can actually cite, but, it's definitely patients are doing. The second, situation is that you have a problem. Some patient has a bloating, some patient has a diarrhea, some patient, they have a problem with gallbladder, they cannot eat, a little bit fatty food, because they feel like they have a little bit pain, on the right side, so of their abdomen, where the gallbladder is, they don't feel comfortable. Sometimes they have a little bit nausea, or, the appetite is going down. So for these patients, I would definitely decrease it, or I would contact with surgeon, whether, for example, they have some problem with the gallbladder, because that medication is causing, like, the gallbladder is not working properly, because it has to actually squeeze, when you are eating something, squeezing, because you need the bile for actually to metabolize the food that you ate, but the gallbladder is like slow, sluggish. So therefore you may have, for example, stones, or some sand, and sometimes the patient needed to be operated. And after operation, usually those patients are doing extremely well, and they can continue with the medication. So there are different reasons, when we actually decrease the medication. But I will not oppose, if your tumor is stable, to decrease the medication, but you have to be very careful. You have to go through the several imaging to make sure that they are stable. And if something is happening, for example, after 6 or 12 months, you can always restart the medication.
Fair enough. Thank you. And thanks for your question, Rebecca. From our friend Kristen, who's excited about being your patient in the very near future. With paraganglioma, is sudden weight gain a concern?
No, this is interesting. Yes, in some of them, they may. Even there are some data that most patients with Pheo Para Alliance sometimes losing weight. This data is not coming from me, so it's a different study, and definitely there are some patients who are losing weight, but there are some patients who may gain weight. The reason may be different, but one of the reasons can be that the patient has a still very good appetite, and has very severe or more severe constipation, because the catecholamines decrease actually the intestinal peristalsis. The intestine is like, lazy, slow, okay? So the bowel movement is not there like it was before on daily basis. In some patients, once a week, some patients twice a week, some patients it's even worse. So they have a constipation, and at the same time, they have a, for example, good appetite. So even catecholamines have actually catabolic effect on some organs and overall, but those mechanisms and other mechanisms which I don't know about, very well, can actually result in rather gain weight or some gain weight than, that would be weight loss. Okay, so of course there may be some other reasons, because this Pheochromocytoma can increase like cortisol, and cortisol definitely increases weight in some patients. So there may be combination of catecholamines as well as cortisol, but that would need to be very well investigated. Yes.
Got it. Thank you. Folks, if you joined us a little bit late or just joined us recently, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. And we are here today with Dr. Pacak from the NIH. We're talking about a lot about Pheochromocytoma and paraganglioma. Keep those questions coming in, and we're going to keep rolling along and answering them. We are about halfway through. Next question from Kay. Dr. Pacak, can you touch on Demser for treatment of paras?
Demser is a miracle drug. I loved the drug a lot, especially in patients, they have a high catecholamine levels, okay? And they cannot be really very well treated because the catecholamines levels are very high. They have a metastatic disease, they have a big tumors, they are releasing a lot of catecholamines. This is only the drug that decrease the synthesis of catecholamines in the periphery. Therefore, the Demser can be very beneficial in patients when, for example, catecholamines are high and you are using antihypertensives, but you are still not there with high antihypertensive. The patient still has blood pressure 150, 160. You have already 2 or 3 drugs, and you cannot deal with that because it's very complicated. Demsr is very good drug. So the problem with Demsr, it's actually distributed, maybe produced, by one company. So extremely expensive drug. So you have to talk with your insurance company whether they will cover, that drug. Or we have this drug at the NIH. If the patients are actually our patients here at the NIH, we definitely like to provide them with the Demsr. I think also Mayo Clinic and other like Tufts University, other medical centers also have some programs for Demsr, but it's miracle drug and I very, very much like it. The only problem is that you cannot use so much Demsr because Demsr goes into the brain. And of course, brain has a lot of catecholamines. And if you have a depletion of the catecholamines, you have like depression-like symptoms and signs. It's not very common if you use, certain doses that are actually recommended and don't go very high up. So it's not very common. It's very rare. So you have to be careful, but it's manageable. It's manageable. Okay.
All right. Thank you very much.
Sure.
Next question from Carrie. My question is there any research or progress being made to be able to safely remove this tumor?
Oh, well,
That's a little
the question is which tumor,
yeah. So he does say, Carrie does
you-
say the net that I have is
Carrie,
well different.
if you tell us which tumor, is it head and neck? Is it, chest? Is it abdomen, pelvic area? Overall, the surgical approaches and some innovations in surgical approaches are extremely good. And I can tell you honestly, most of tumors can be surgically removed. There is only very small fraction of patients when tumors cannot be removed, whether they, for example, they are very big, they are abutting, some big vessels, there are in the area that would require sacrification of, for example, major portion of lung, or, in the brain, or, some other areas. So, but most of the tumors, especially when the patients are coming early, can be surgically removed.
Okay, got it. He just Carrie just chimed in the omentum.
Omentum? Oh, that's interesting. That's very challenging question. Yes, it can be, but usually requires very long operation. And usually from omentum, our surgeons very often take one tumor, each tumor by tumor. Okay, so because there are sometimes many tumors, and you have to definitely take all these tumors. So there are some other surgical procedures for omentum that surgeons will most likely comment better than I would. But yes, there are some options, that can be considered and sometimes can be done. It depends what is outside of the omentum. If you have tumors in the omentum, you should definitely contact me, because I can talk with our surgeons. They are doing those operations here. If you have many other lesions somewhere else, it may not be absolutely the most helpful, and we would suggest something else. It really depends on the picture and everything what you have, so, and the assessment. But we would be definitely happy to help you, because our surgeons definitely doing that.
Got it. Thanks very much. And thanks, Carrie. Next question from Rose. Rose says, my serotonin is 1395 and pancreastatin is 499 and chromogranin A is low with no liver metastasis, but small grade 1 tumors, less than 1 centimeter in the abdominal cavity. And so the question is there a correlation between the high numbers of these markers and or the size of the tumors and the size of the tumor?
Yeah, I don't know if Rose is talking about Pheochromocytoma or carcinoid. because it sounds like, it's carcinoid or / neuroendocrine tumor,
Mhm.
rather than pheochromocytoma, because pheochromocytoma does not present with this. And especially, serotonin, and I think you said pancreatic polypeptide, so something, so this is most likely neuroendocrine tumor. And of course, if they are elevated, definitely yes, because it's actually related to tumor burden. It's interesting that chromogranin is not elevated, because usually chromogranin is pretty good. It's not, I would say, magic or anything like that, but it's pretty good and reliable in these patients, especially with neuroendocrine tumors.
Mhm.
So here I think that goes a little bit to neuroendocrine tumors, and would need to go to some specialist in those tumors, because, pheochromocytoma with serotonin and, for example, pancreatic polypeptide, so practically non-existing.
Got it. Thanks. Next question from Lisa. This is interesting. Some European groups advocate for not needing alpha/beta blockers before Pheo Para surgery. What are your thoughts?
Yeah, my thoughts are, that, for example, that is not something that I would support. And I will tell you, for every patient, I will tell you quick scenario. For example, you have a pheochromocytoma. You have pheochromocytoma diagnosed January 1st. You are leaving, the office of the doctor, and he will tell you you have a pheochromocytoma. You came to the doctor with high blood pressure, palpitations. You know that your catecholamines/metanephrines are elevated. So therefore, you need a blockade. You will be scheduled for surgery, for example, in 3 weeks. Okay, so 21st of January, it's your surgery. So some advocate you don't need blockade. Why? Because anesthesiologists today are very good, and they are, and they can counteract, any problematic blood pressure and heart rate during the operation. But imagine one thing. And this one thing is that you have to still live with this pheochromocytoma paraganglioma for 3 weeks before you are operated. What about if you will be in accident? What about if you will be in psychological situation that somebody calls you that you lost the job, or somebody will call you that your relative is sick, or somebody will call you that you have to do this and that, or you are, for example, in complicated situation. You will be under stress. Every stress, psychological stress, physical stress is usually activating these tumors, and you can have very high release of catecholamines. I saw several patients, or you can be in an accident. Accident happens, yeah, and there are many accidents on the highway, and I'm positive if you will be under, the accident, you will have complicated situation, and tumor will release huge amount of catecholamines. If you don't have that blockade, you will be in terrible situation. You will end up with myocardial infarction. You can end up with stroke. You can end up with complicated arrhythmia. You can end up with many problematic, I would say, outcomes. Yes, blockade sometimes does not, I would say, prevent you from everything, but actually mitigate or lessen all these, outcomes that you may be exposed to different situations. And that's very important. It's not the blockade that you need during the surgery. You need the blockade from the time when the tumor is removed, because you don't know when your surgery will be or what will happen to you from the time when the tumor was found until the surgery. This is the same like somebody would have cough, the fever, some sputum positive, and they would say, oh, you don't have a pneumonia. You don't need actually antibiotics. The person needs antibiotics because the microbiology is positive, the results. And waiting for pneumonia, then it's sometimes too late, okay? Because the patient can get a lot of other problems. You have to fix everything at the beginning. And I can tell you honestly, in US would not fly very well for doctors, so if they would not give you the blockade and something would happen to you, before, during the time before surgery, unless you refuse it and say, no, I don't need any blockade. I will wait, for a surgical procedure. That is up to you. But otherwise, based on the guidelines of U.S. Endocrine Society and many other guidelines, right now the blockade is definitely recommended, and is recommended practically immediately when the tumor is found and it's positive based on the biochemistry. Okay, even if you don't have a high blood pressure at the time, and if you don't have a high heart rate, but you already have the positive biochemistry, that can be devastating when you are in complicated situation. And trust me, I saw several patients and they end up with complicated, critical situation because they were actually in the situation they did not have a blockade.
Got it. Hey, thanks, Lisa, for your question. Next question from Anna. Which laboratory measured serum methoxytyramine level?
Oh, that's very interesting. So, the patient must have very good information about methoxytyramine. The methoxytyramine is measured only at the NIH, but I heard just now that there is, some lab in the Utah and maybe Salt Lake City that is measuring methoxytyramine. I don't remember just now the name of the person, but there is definitely one lab that can measure 3-methoxytyramine. Unfortunately, only 2 labs, to my best knowledge. Maybe there are more right now. In Europe, there are many measuring methoxytyramine, and you need methoxytyramine for some mutations, but unfortunately, US is a little bit behind with the methoxytyramine. I apologize for that.
Got it. Thank you so much. From Corey, you talked about epinephrine being constant. What is the better test for this, plasma or 24-hour urine?
No consensus reached, but I can tell you honestly, I would prefer plasma because, if you combine sensitivity and specificity, so that is slightly higher for plasma than for urine, okay? So plus urine, you have to collect 24 hours. You cannot, during that time, you cannot have alcohol, smoking, physical activities, anything under the stress. You are always carrying, the jar, for the collection. You have to, sometimes you have to put a refrigerator, sometimes not. It depends what they give as a preservative, so it's complicated, okay? And you have to go to the doctor the first time to take it, then the second time, to return it. It's a lot of work. So plasma methanephrine's are extremely good, extremely accurate. You don't have anything to lose. The only problem is that with plasma methanephrine's, you should talk with lab that will be doing that you can rest, which means that it will not be in sitting position, but will be just, in supine position, and they will let you rest at least, for 15-20 minutes, because this is very important, okay? Not every lab will do it, but there are definitely labs. They will let you actually to be in the chair. They put the chair a little bit down that you will be almost in supine, the position, and they will do the test, okay? Very often, this test is done very properly at the university or tertiary center, so if you have any doubts, I would definitely contact those, then to go to, for example, Quest or, some other labs that they are doing routine lab and everybody is sitting, but the plasma is slightly better, but there is no consensus at the present time.
Got it. Thank you. Folks, we got about 15 minutes left, so keep sending those questions in. This next one comes from Jennifer. My surgeon is recommending if they cannot get all the tumors, they potentially do an alcohol ablation through endoscopic ultrasound technology. Could that work? And she has a paraganglioma and organ of Zuckerkandl.
Yeah, definitely not. I am not in favor of that procedure. Okay. And if that was Jennifer or somebody,
yes,
Jennifer, you can contact me and you can share your situation with me, and I will review your actually images and everything, and I will tell you what can be done or what cannot be done.
Can you
Uh,
elaborate a little bit why you think that's not a great
because
idea?
there are not good data that alcohol would help, and it can be complicated, and I don't see any reason why the tumor cannot be removed. Of course, it can be very big, it can be around the vessel, but let me to review the images. We do quite a lot of patients with organ of the candle paraganglioma, and not long time ago. So pretty good experience. We will tell you immediately if you are a good candidate for surgery or not. But for the alcohol, I can tell you there is not good study, and I am not definitely in favor.
All right, thank you very much. And you heard the offer, Jennifer. I would definitely take him up on that. So hope that helps. But let me know if you have another question. From Melanie, when would PRRT be considered as an option to surgery? Look, I'm sure that depends on many variables, but if we can talk about it
There
generally.
are many variables, but PRRT would be, when the surgery cannot be done. Okay, so this is simple. If you have too many lesions and these lesions are, for example, not growing very fast, it's slow/moderate growth, then I would definitely suggest, to consider PRRT. I would consider surgery only if it is imminent, for example, mass effect, the tumor is pressing on certain area, the patient has, for example, pain, has some other problems, that of course the surgery will be okay. The other option for surgery will be if you have a very high catecholamine levels and they are causing very problematic hypertension, and you can end up with stroke or with arrhythmia, myocardial infarction. Here, I would do palliative surgery, even if you have, for example, other lesions, because, if you remove, big tumor that is, for example, 8-10 centimeter, can you imagine that will be millions of molecules of catecholamines removed from your body? You will definitely improve, okay? But otherwise, if you have other lesions in the body, and they are positive on dotatate, for example, I would definitely to consider the PRRT, but only if these lesions are growing, so except for if you have too many lesions, for example, in the liver or lungs, and they don't need to grow, they can be even stabilized, then I would consider, to have to have the PRRT treatment. Okay.
Got it. Thank you. This is from another Jennifer. Any net-related reason for dizzy, feeling disoriented often? She is on gabapentin.
Yeah, so definitely yes, because it depends what the operation was. And for example, baroreflex can be affected if it was carotid body and a little bit higher up, so because it's actually controlling, the blood pressure through parasympathetic nervous system, and so that can be problematic. So definitely, I would consider to go to the surgeon or to facility and to be assessed, for any, I would say, abnormalities in heart rate, blood pressure, when, for example, standing, sitting, there is something which is called tilt test, and everything, whether, some structures in the neck were actually affected. We see it from time to time in some patients that they can be dizzy, because it really depends what kind of structures are actually involved, but it's very often related to baroreflex.
And folks, this is a good opportunity to reiterate my point about the shared experiences and shared stories among the community. Jennifer, I don't know if you saw, but Brian chimed in with his experience with gabapentin too, which was similar results, and he offered some suggestions. So try to find that comment too. But this is a good opportunity for folks that might have experienced similar things. And to that point, Brian has a follow-up question to the alcohol ablation question that we had. Could some of the other options include TACE, TACE, radio frequency ablation, or cryoablation if surgical debulking is not possible?
Yeah, absolutely. So the cryoablation or radiofrequency ablation very good, and definitely recommend it. And they can be very successful. It depends on the size of the tumor as well as the position of the tumor, which means what is the location of the tumor. For example, if that would be close to big vessels like in the liver, that will be problem because heat will destroy those vessels. They will rupture and you will bleed out. Okay, so you have to have, certain size of the tumor as well as the location. But, for example, in the liver, peripheral location, or in the bone, or in the rib, for example, in spine, or even in the abdomen, you can use the radiofrequency ablation, and we are using it, and it can be sometimes very successful. And the patients, they don't need, for example, operation, or if they have 2 or 3 small lesions in the liver, they are not close to the big vessels. This can be done radiofrequency ablation. Patients usually go home next day. Yeah. So it really depends. Everybody is different, has to be individualized, and everything has to be reviewed very carefully before one of these procedures is actually recommended.
Thank you very much. Question from Lisa. Many healthcare providers still use the rule of 10. How do patients ensure they are getting proper follow-up? And then she says 10% familial, 10% bilateral, 10% malignant. Malignant Pheochromocytoma has a high, you know where we're going.
Yeah, so forget the rule of 10. It does not work. Okay. It's obsolete, does not, so if your doctors are following the rule of 10, so I understand because they don't have a lot of experience with Pheochromocytoma, paraganglioma. The rule of 10 is really not valid anymore. For example, hereditary 40%, metastatic, 30%. Okay. Multiplicity, usually 20-30%. So I don't. Adrenal are usually about. Or put this one extra adrenal 25-30%, so not 10% like used to be 90% Pheo, 10% paraganglioma. Does not work. Okay, so don't even think about that. And I understand doctors may not have enough experience. They may be excellent doctors because they are focusing on something else, but try always to find somebody who is good, because I always tell patients, but somehow some of them, they don't listen to that. And this is again my personal view, so these are very rare tumors. Go to the places where rare is common. Okay, that's very important. Okay, you don't want to go to places when, for example, they see 2 or 3 cases per year, because you have something which is rare and you have to get the best information. You deserve it, your health, your life, your outcome. Okay, so this is why I think it's very important. We have an excellent physician outside, but everybody has a certain niche. Okay, I cannot treat, for example, patient with diabetes, even in, so I am certified in that, so, and because, I don't do patient with diabetes, so not everybody is doing Pheochromocytoma. This is nothing wrong, because they are very smart, very clever, physicians, but go to somebody who has the experience. That is my definitely good advice. And I can tell you it pays off, in long run. Even if you have to go somewhere, whether you would go to Tufts University, you would go to Mayo, you would go to NIH, you would go to somewhere else, MD Anderson, but it pays off, later on, because you will get very good actually care, and usually in most places also comprehensive approach.
Got it. Thank you. From Sherry, how often should we have PET scan surveillance after adrenalectomy?
Yeah, that depends, what was the tumor, So I would say that after adrenalectomy, I would most likely, or there will be new recommendations coming, So PET scan, if it would be hereditary tumor, so definitely maybe 3 to 4 months. I usually suggest between 3 to 6 months, because the first 3 months you cannot have a PET scan because there are a lot of scar tissue, a lot of fibrosis, inflammation that can be positive on the PET scan, and it can be false positive. So don't ever accept any PET scans during the first 3 months after the surgery. Later on, yes. And the reason why you would have the PET scan, whether your operation was successful. Because if the PET scan was positive in the before operation and just now is becoming negative, your operation was successful. Okay. And then, how often? It really depends on the size, on the type of the tumor, but we usually recommend every approximately 3 years or so. But between, you will have a CT or MRI or the biochemistry. But the PET scan does not need to be every year. First of all, it's very expensive. Not everybody can afford it, and it's enough if you will have a plus minus every 3 years or so.
Got it, folks. We've got a few minutes left. We're going to try to get to a couple more. From Christy, is Sandostatin just as good as lanreotide?
Oh, it's very interesting question. Very smart question. Yes or no? And some patients are doing better on lanreotide. Some patients are doing better on octreotide. I think that there is no really very good study again and very good approach how we will find out whether something is better over another one. But what only you have to do is, just to use it and see, so what is happening? Like, you have an allergy medication, yes? How many allergy medications exist? And some people, they like this one. Some people, they are better on another one. So, and this is, or hypertensives, antihypertensives. This is the same. You have to really try, what you like better, how you feel, and of course, what is happening with your tumors. Okay, there's both are very good. Both have pluses and minuses, but everybody reacts on each one sometimes a little bit different way. Okay.
Yeah, that's a common question we get here on the show too.
Yeah.
From Melanie, does stress have an impact on NETs?
If stress, if somebody is under stress, whether there is impact of neuroendocrine tumors?
That's the question.
Yeah. So look here, every stress, what is during the stress? I would say yes, the data is most likely not there so much. But if you have, for example, especially chronic stress on daily basis, that what is happening? Decrease your immune system. If you have the immune system that is decreased, of course, will not very efficiently fight cancer cells. So patients who are in good spirit, good shape, otherwise they exercise despite what they have, and they take it a little bit easy way. Not everybody can do it because we all are different, and I fully understand that. But if you can avoid some stressful situation or stress, I would recommend it, especially, the chronic, if it is short one, short lasting, that would be most likely, unless it's very severe. But I think that would be good. But for long lasting, I think that could actually negatively impact neuroendocrine tumors and cancer in general.
Got it. Thank you. From Rick, is there any reason to do both urine and serum epinephrine levels?
No, definitely not. Excellent question as well.
Yeah.
Choose one, but I told you there is no consensus. If you can choose one, I would always go with the plasma. And I told everybody what you need to do with the supine position, rest, etc. But I will go with the plasma. But if you cannot do plasma because of ABCD, including insurance, even if you do the urine, that will be fine. You will be okay.
Got it. Folks, that is the hour. That is our show. Ruby says, good show. Thanks, Rain, Dr. Pacak, and CCF. P.S. Love your shirt, Rain. This is a very important announcement. Thank you, Ruby. Appreciate it. This is Lululemon. So, Dr. Pacak, I appreciate your time so much, and the people are all chiming in with their comments. They appreciate you as well. Thank you for spending some time with us again and sharing your experience and information.
Thank you. Thank you so much for having me. And as I said, I will be very happy, to talk to patients. If you send me email, I hope that we will maybe meet together next year. And I know that you have a certain program and certain schedule and everything, but I will not really oppose, if the patients will vote and will send to your organization that they would like to spend more time with me. We can even talk sometimes 1.5 hours, 2 hours. It depends on the organization. But I am giving you this option. As I told you, I learn from you, you learn from me. And it's always a mutual, I would say, relationship, which is very important. So I can tell you that I don't really mind, because I like to talk with patients. I like clinical questions. All the questions were absolutely fantastic and great. And thank you so much for participating in this event. And thank you, Ryan, for the introduction and being a wonderful moderator. Thank you.
I appreciate it. And we had people chime in earlier that said they would definitely stick around for 2 to 3 hours, as you were mentioning earlier.
I will take it next year.
All right, that sounds good.
Try to support it, and I am yours.
Well, Donna says, this was a great show. This doctor was an awesome speaker. I totally agree. Thank you again, Dr. Pacak, and thank you folks at home as well for being here. We hope that this program helped answer some of your questions, and I'll reiterate, if they did not, or if you have follow-up questions, reach out to Carcinoid Cancer Foundation. Tune in next week. Stick around. This is our job. We are here every week to help answer these questions. Thanks again, as always, to our presenting sponsor, Ipsen Biopharmaceuticals. We could not do the show without them. And finally, my name is Rain Bennett. I have been your host. Thank you for watching. And please join us next time on Luncheon with the Experts. Stay healthy. Stay safe, everyone. Bye-bye.
Okay. Thank you. Bye-bye. Bye-bye.